Hello students. In today's session we are going to talk about the role of knowledge in health professional and patient communication, as well as the wider role of information in illness. Well, it is well said by Terry Cannell that the patient will never care how much you know until they know how much you care. On the other hand, medicine is supposed to be an art whose magic and creative ability have long been recognized as residing in the interpersonal aspects of patient and physician interpersonal relationship, according to Hall, Rotter and Rand. Well, advances in biomedical and behavioral sciences have paved the way for integration of medical practice towards a biopsychosocial perspective and approach. Dealing with health and illness overtakes looking for the presence or absence of a disease or some kind of infirmity, illness. It's a biomedical paradigm that we are talking about right now. And to that shift, from there is a shift to the biopsychosocial paradigm, in which health means a state of complete physical, psychological and social well-being. Well, a doctor's role is not just limited to diagnosing and treating the illness medically, but also there is a role of the doctor in understanding the psychosocial perspective and in dealing with the patient as a whole, not just as a considering the medical disease or illness. Communication between the doctor and patient then becomes an important tool, and it is very necessary for the basic treatment plan. A doctor's communication and interpersonal skills encompass the ability to gather and also provide the right kind of information to the patients. And this will help in the facilitation of number 1, accurate diagnosis, number 2, counseling the patient appropriately, number 3, giving therapeutic interventions, and also in establishing caring relationships with the patients. There are 3 main goals of the current doctor-patient communication per se, and these are number 1, creating a good interpersonal relationship. The second one is facilitating exchange of information. The third one is including patients in the decision-making process. Decades of research show that and agree that successful attempts to improve patient adherence depends upon a set of certain key factors. Now let us look at these key factors which are important for the adherence of the patient. These factors are basically a realistic assessment of the patient's knowledge and understanding of the treatment regimen, and a clear and effective communication between the health professionals and their patients, and the nurturance of trust in this therapeutic relationship between the doctor and the patient. In addition to that, there is a mutual collaboration which fosters greater patient satisfaction and reduces the risks of non-adherence, and also improves patients' healthcare outcomes. Let us now talk about the role of knowledge in a health professional and the patient communication, which we have been discussing so far. Here we have to talk about the importance of Lay's work. Lay carried out a wide range of thorough and critical analysis of a key subject of doctor-patient communication, and he came up with certain findings. Lay in 1977 has detailed about the patients failing to comply with doctor's instructions. Why? He says it is partly due to the patient not understanding the instructions of the doctor, partly because they are not persuaded, the patients are not persuaded to the need of importance of the treatment prescribed. Yet another reason may be because they have forgotten. Based upon all these things, Lay proposed a cognitive approach to doctor-patient communication, and he stressed the value of comprehensibility and of also the methods of facilitating recall. Thus came out the educational model of knowledge, which was proposed by Lay, and Lay's approach to this health professional and patient communication can be understood within the framework of this educational model. and this involves a transfer of medical knowledge from expert to a layperson. Now this is a traditional approach, and this has motivated a lot of further research into health professionals' medical knowledge, which is seen as a product of both their training as well as their education, and accordingly the communication process is seen as originating the base of health professionals' knowledge. Now there are of course differing perspectives which we may discuss now. Boyle, way back in 1970, though he has emphasized upon the patient's knowledge, he also provided insights into doctors' knowledge of the location of organs, causes of variety of illness. There were different perspectives. The results showed that although the doctor's knowledge was superior to that of the patient, some doctors wrongly located organs and wrongly defined problems. Definitely there have been a lot of changes in the government policies everywhere, as well as the resultant actions as well. So what happened was primary care team members are spending more and more time with the patients with respect to the health promotion practices, and they often involve in making necessary recommendations about changing behavioral patterns such as smoking, alcoholism, drinking, diet patterns and others. Now let us also briefly look at certain other research reports based upon the findings that we have discussed so far. Research has examined health professionals' knowledge about certain practices or various practices. Murray and others in 1993 have examined the dietary knowledge of the primary care professionals in Scotland. So general practitioners, community nurses and practice nurses, they completed a questionnaire which consisted of a series of very commonly heard statements about diet, and they were asked to state whether they agreed or disagreed with them. The results showed high level of correct knowledge for statements like most people should eat less sugar, most people should eat more fiber, and there was relatively less accuracy or poor accuracy with reference to statements like cholesterol in food is the most important dietary factor in controlling blood lipid levels. So Murray and others, the authors, have concluded that primary healthcare professionals generally show good dietary knowledge, but there is clearly an urgent need to develop better teaching and training in the dietary aspects of coronary heart disease. So there was a requirement for a better training. Let's also talk about the problems with relation to this traditional approach, which refers to communication between the health professionals and patients. Traditional models of communication between health professionals and patients have emphasized transfer of knowledge from expert to a layperson. Now, Lay's cognitive hypothesis that we have discussed, model of communication, includes a role for the patient and emphasizes patient's factors in the communication process as well as health professional factors. As we have discussed, provision of relevant information. This approach has encouraged research into wider role of information related to health and wellness. However, there are several problems with relation to this educational approach that we have been discussing. This approach assumes that communication from the health professional is from an expert, whose knowledge base is one with objective knowledge, and it does not involve the health beliefs of the individual health professional. Patient compliance is seen as positive and also as unproblematic. Improved knowledge is predicted to improve the communication process, and it does not include also not only the role of health beliefs of the health professional, but also it does not include the role of the patient's health beliefs. Then came an attempt to talk about the adherence model of communication. In an attempt to further our understanding of this communication process, Stanton in 1987 has developed a model of adherence. The shift in terminology is from compliance to adherence, and it illustrates the attempt of the model to depart from the traditional view wherein the doctor is an expert who gives advice to a compliant patient. This adherence model that we are going to talk about suggests that communication from the health professional results in an enhanced patient knowledge as well as patient satisfaction. In addition to that, there is an adherence to the recommended treatment regime. To this extent, the adherence model is also similar to the LACE model that we have been discussing so far. In addition, there is a suggestion that patients' beliefs are important, and this model also emphasized that patients' locus of control, perceived social support, and disruption of lifestyle. All these are involved in the adherence of the patient. This way, the model progresses from LACE educational model, and it also includes aspects of the patients and emphasizes the interaction between the health professionals as well as the patients. Now, doesn't adherence model have any problems? This also has problems. Yet again, this model of communication assumes that the health professional's information is based on objective knowledge like in LACE educational model and is not influenced by their own health beliefs. And patients are regarded as lay people with their own varying belief systems and perspectives that need to be dealt with by the doctors. And they have to be addressed in terms of the language and content of the communication. In contrast, the doctors are regarded as objective and holding only professional views. We will now discuss about the wider role of information in illness. Well, information and recovery from surgery is a much discussed topic in the research related to health communication. Information provided to the patient may not be only about the diagnosis, about the treatment, and about the procedures which are going to be followed. In fact, it may also be related to the recovery. It is necessary that it should be related to the recovery and also the outcome following the illness or surgery. On the basis that the stress caused by the surgery may be related to the later recovery, that is recovery after the surgery or whatever, Ennis in 1958 has interviewed patients before and after surgery, and he wanted to examine the effects of preoperative fear on post-operative recovery. So he examined the differences between preoperative extreme fear, 3 types. Number 1, preoperative extreme fear, moderate fear, and little or no fear of the outcome. So extreme fear, it was seen, was reflected in patients' constant concern, anxiety, and reports of vulnerability. On the other hand, moderate fear was reflected in reality orientation, with the individual seeking out information about whatever is going to happen, and little or no fear, the third aspect, was reflected by a state of denial. Moderate preoperative fear was related to a decrease in post-operative stress. Now, Ennis suggested that moderate fear results in the individual developing a defense mechanism, certain coping strategies, seeking out relevant information, and rehearsing the outcome of the surgery as well. So this approach may lead to increased confidence in the outcome, which is reflected in the decreased post-operative stress. So how can you use the information to improve recovery? If, as we have discussed so far, stress is related to recovery from surgery, then obviously proper information, necessary information, could be an important way to reduce stress. There are different types of information which could be used to affect the outcome of recovery from a medical intervention. What are these kinds of stress? Let's discuss them. Number 1, it is sensory information. This can be used to help individuals deal with their feelings or to reflect upon these feelings, how they are going to feel. Procedural information, on the other hand, enables individuals to learn how the process or the intervention will actually be done. Coping skills information, on the other hand, can educate the individual about possible coping strategies. And the fourth is behavioral instructions, which teach the individual how to behave in terms of factors such as coughing or relaxing and others. Let us see how these types of information can be useful to a patient. Let us see certain research studies which have shown the usefulness of these different types of information that we have discussed so far. Researchers have evaluated the relative roles of these different types of information in promoting recovery as well as reducing the distress that the patient faces. Johnson and Leventhal, way back in 1974, have given sensory information to patients before an endoscopic examination, and they noted a reduction in the level of distress experienced by these patients. In 1964, Egbert and others gave sensory information again and also coping skills information to patients in hospital who were undergoing abdominal surgery. And these researchers have reported that sensory and coping information has reduced the need for painkillers as well as reduced the hospital stay by a few days. In 1985, Young and Humphrey gave information to patients going into the hospital, and they found that information specific to how they could survive the hospital reduced the distress in the patients and also reduced the length of their stay in the hospital. Johnston in 1980 has found that preoperative information can influence recovery, can reduce anxiety, pain rating, length of hospitalization, as well as analgesic intake. Johnston and Fogel in 1993 have conducted a meta-analysis, and they concluded that preparation for surgery in the form of both procedural information and behavioral instructions, two types of information, that is procedural information and behavioral instructions, resulted in significant benefits in terms of outcome variables which have been explored, for example, mood, pain recovery, physiological indices, and of course the satisfaction of the patient. How does this preoperative information help? There might be certain reasons why preoperative information can be helpful, yet it is not very clear. There are certain possibilities that we can talk about. For example, it is possible that preoperative information may be beneficial to the individual in terms of reduction of anxiety by enabling the patient to mentally rehearse the anticipated worries, fears, and changes which might follow the operation. These results so far discussed suggest that information communicated to the patient correctly by a doctor or a health professional may be an important part in reducing the distress following the surgery, following the hospitalization, or any other intervention. However, is there no problem related to this preoperative information and the research related to it? Well, research exploring the communication process highlights how health professional beliefs relate to the behavior in terms of diagnosis, management, and referral. It's possible that their behavior also influences their beliefs, and these beliefs and behavior exist in a dynamic relationship. The current emphasis within the clinical care system is on patient-centeredness, shared decision making, and informed decisions. So this particular view emphasizes respecting the patient's perspective, patient-centeredness, and understanding also the patient's beliefs. However, health professionals also have training and expertise which encourages them to feel that they know what is the correct mode of management and what is the correct way forward. At times, these two perspectives which we have just discussed might clash with each other. Research exploring the interaction between health professional and the patient uses a variety of methods as well. Some studies ask partly about the interaction, and some may record the interaction, some code the interaction, and some may observe the interaction. All these methods that we have been talking about involve a level of interpretation by the researcher, by the health professional, or the patient. Trying to access what really goes on in a consulting room then is really not possible. Let us now discuss the strategies to increase knowledge about the condition and also increase adherence to the treatment. Lay in 1988 has suggested 3 strategies in the consultation that can increase the knowledge about a condition and also adherence to any particular recommended treatment regimen. The first is maximizing satisfaction with the process of treatment. Second is maximizing understanding of their condition and also its treatment. And the third is maximizing memory for the information given. Let us discuss each of these individually. We'll start with maximizing satisfaction. Now, there are certain factors which might contribute to maximizing satisfaction, like for example, having sufficient time in the consultations to fully discuss the relevant issues with the patient seeing the same health professional on repeated visits. Having good accessibility to health professionals also helps in maximizing the satisfaction. Patients report relatively low levels of satisfaction with health professionals who adopt a strong biomedical stance alone during their consultation, and they pay very little regard or attention for the social and emotional concerns of the patients. They would be happier if the psychological and social emotional issues of the patient are also given due relevance and importance according to researchers. Such a consultation style, where not only the medical issues but also psychosocial issues are given importance, may relate to patient preferences for health professionals who work at building a relationship with the patients and give more positive nonverbal communication and behavior, who demonstrate positive nonverbal behavior and also give more positive talk according to certain studies. Now let us look at this maximizing understanding aspect of it. How does that happen? Many people leave consultation without the information that they want. They may want certain information, but for a variety of reasons they may leave the consultation without having a proper information. Now, health professionals, for example, may lead the interview and perhaps without realizing it may inhibit the patient from asking certain questions which they originally wanted to ask. On the other hand, the patients may also not think through properly as to what information they want, or realize only after leaving the interview what they wanted to ask, what they could have asked, or what they should have asked. They may also be reluctant to ask questions to doctors who are still seen as those on a higher status than that of the patient. To avoid any such lapses that we have been discussing, a number of studies have examined whether preparing patients before a consultation can help them ask questions, relevant questions, to elicit the information that they actually want in a consultation. The results of the studies, the data, suggest that encouraging patients to be actively involved in consultation by prompting them to voice opinions or to ask clarifying questions will result in understanding the health problem that the patient is facing and also how these might best be treated. Now, the third aspect that we have to discuss yet is maximizing memory. Memory for information given in consultations is surprisingly poor. Lay, way back in 1997 once again, summarized the relevant data which suggested that half the information which has been given in consultation is forgotten almost immediately by the patient. In time, patients may forget their own actions as well. There has been a study which has been done by Montgomery, Leiden and Lloyd in 1999, which reported that nearly a quarter of patients undergoing radiotherapy for the treatment of cancer would not recall having signed a consent form which permits the treatment, in spite of there being a clear evidence that they did sign the form. While half of them do not remember being told about the side effects of the treatment, like for example the feelings of exhaustion. The more information that is given in consultation, the less is likely to be remembered. Hence, Lay in 1997 has developed a simple rule of thumb. He suggests that 75% of information given in 4 statements is likely to be retained, while 50% of information given in 10 statements will be remembered. So, a number of ways of providing information thus may enhance memory for whatever has been told in consultation. What are those ways of promoting memory? Number 1, using a structured form. Information is best provided if it is provided in a structured form. For example, you use statements like, I am going to tell you 3 things. A, this. B, this. C, something else. So you provide it in a structured form, it is remembered better. Using language and terms that the patient can understand. The most important information should be given either early or late. In the flow of information between the health professional and the patient, remember, this maximizes the recency effect and the primacy effect. And its importance should be emphasized as well while giving information. In addition to these, certain strategies like repetition and using specific rather than general can be used. Then the second important thing is, in addition to the structured form, the type of language used by the health professional. For example, in the study done by Loeb, Berto and Kenny and others in 1999, they found significant misunderstandings of the information on prognosis and survival given to women diagnosed with breast cancer. 73% of their sample did not understand the terms like median survival or good prognosis. Even much simpler terms may not be understood by many patients. Remember, there might be a difference in understanding. Words such as arthritis, jaundice, antiemetic, dilated and hemorrhoids, these are all not understood according to lay by nearly half the population. Use of jargon, these technical words, may even result in significant anxiety from a psychological perspective. There was a study by Abramsky and Fletcher in 2002 which found that the use of words like rare, abnormal, syndrome, disorder, anomaly and high risk and such other terms in the context of genetic screening were particularly worrying to patients. These subtle uses of language show how careful healthcare professionals should be in talking to patients, in communicating with patients. Now, the third is provision of more permanent material. This is one of the forms of maximizing the memory for written information. This can have significant benefits over verbal information alone because it can provide an opportunity to give carefully prepared information which is presented in a way designed to be maximally effective. It provides a record which can be time and again consulted and that can remind patients of salient information. Ideally, the potential content of any written information should be based on some preparatory research, and in that the patient group should also be involved. That increases the chances of information being relevant and appropriate to its intended readership. An example can be seen in the research by Glenton, who conducted interviews with back pain sufferers so that he can develop an information pack for people with back pain. They wanted to know about diagnostic procedures, alternative treatment, information about social, emotional costs of this long-term pain. Remember, it's back pain, how to cope with their everyday life and other people's experiences, and of course their welfare rights. Now, the use of written information should take into account the same issues which relate to the spoken information. Whatever has been verbally provided by the doctor or the medical professional has to be in line with the written communication. It needs to be clear, it needs to be jargon free, and at a level of complexity not so high that it makes it unintelligible to the general population in general. With this in mind, whatever Lay has said, about a quarter of published medical leaflets would be understood by only 20 to 30% of adult population is of particular concern. We have to think about it seriously. In a similar study, Alexander also in 2000 reviewed American dental educational leaflets and found that 42% of them were written at a complex level and they could not be understood by majority of patients. In fact, he said that it needs at least a university level education in order to understand. Now finally, beyond the consultation, whatever transpires in the consultation, patients have to be motivated. They have to remember to take their medication and follow the advice which has been given as a part of their hurly-burly in the everyday life. Any intervention which is designed to maximize adherence has to take the contextual issues also into account. McDonald, Garg and Haynes in 2002 have examined the effectiveness of 39 interventions that did this and were designed to enhance adherence to medication in a variety of chronic health problems which included chronic heart disease, hypertension, asthma, chronic obstructive airways disease, HIV infection, rheumatoid arthritis, epilepsy and others. These researchers have concluded that most effective interventions are generally complex and involved combinations of the aspects that we have been talking about all this while. Let us recall whatever can be added in such interventions. Number one, a convenient time for taking the drug. Relevant information which can be written, which has to be spoken also. Reminders to take medication And then self-monitoring, monitoring their own selves, like for example, noting down when and where the medication has to be taken. In addition to that, reinforcement of the appropriate use of medication and of course, family therapy. We cannot leave out the family from this regimen. They also noted that the most effective intervention had modest effects. Perhaps the simplest approach to increasing adherence are those targeted at what are assumed to be lapses in memory. Thank you.